Evening and welcome to Black Doctor. I am your host, as usual, Dr. Renee, and today is another episode of the Black History of Health. Tonight's big star is Minnie Ripperton, and Minnie Ripperton, she died way too early, 31 years old. She died of breast cancer. So, of course, we have to handle housekeeping. I need everyone to start a watch party. We do this every week. Please like and start a watch party. I know that you know somebody that has had breast cancer, thought they might have it, or unfortunately lost somebody from it. So please make sure that you share this out right now. And as usual, you can put your comments. We have a survivor who happens to be a physician, and we also have a fabulous and amazing breast cancer surgeon who is going to educate us so that we know what to look for and what to do. Like I said, it's very unfortunate that my Minnie Ripperton died so young, but we don't know, but possibly if it was today, perhaps she would have lived longer, but we will talk about that. And thank you. I see everyone is coming in. Please don't forget to comment. And just let us know if there's any questions you have. Please let us know, and I will make sure you have the information of the physician so that if you do need to send them a message or you may need to see them, that you can. So tonight we have Dr. Ryland Gore with us. She is a breast cancer surgeon, and we're so excited to have you. So thank you for being with us this evening.
Thank you so much for having me. I'm very happy to be here. So this is going to be a great discussion. I love Minnie Ripperton. And I love educating our people about breast cancer. So I'm ready.
Yes. And, and I'm a huge fan of hers as well. So I have to tell you guys, my mother is from Detroit, and Minnie Ripperton had family that lived across the street from my mother growing up. And my mom and Minnie Ripperton are the exact same age. If she was still living, and my mom, that was her playmate. And the girl would come every summer from Chicago, and this is who she would hang out with. So I have to tell you this funny. So who remembers Kwame, the rapper? Okay. Well, yep. Kwame came out with Loving You, right? And me and my sister thought the song was so great, and we he, and we're singing away. And my mom says, my friend sang that song. I go, no, your friend's not Kwame. And she blew her off. So then when Shanice came out with the remake and we were older and kind of understood a little bit better, we were like, oh my God, you knew Minnie Ripperton? So
your mom was like, cut it out.
Right. And she just let us go too, because she's like, I'm not gonna argue with these girls. So you guys, Dr. Alexea has joined us. This is our breast cancer survivor. So we will definitely be talking to her soon. But first, Dr. Gore, please, well, I'm gonna call you Dr. Ryland because that's what we do around here. Yeah. Dr. Ryland, please let us know, what are we looking for when we do those home breast care, self-breast exams?
So number one, do this every single month. I will let you know there are organizations that actually recommend that you don't. They say that it is of no utility. I think that is absolutely ridiculous.
I just have to say, as Black women, Black girls, we definitely need to not listen to that, and we need to do them. And I'm sure she'll let us know why.
Because at least half of my patients have found their own cancers. Most of my patients, they show up to the doctor. Whether they get taken seriously or not, depending on who they go to, is a whole separate conversation. And something that Dr. Alexea is also going to speak with us about today. But over half of my patients have found their own tumors. And so you need to do this every single month, usually the same time of the month. Because
what age do we start?
Teens, 20s. I have these young girl. My youngest patient that I actively take care of is 10 years old. Obviously, I'm not expecting a cancer in a 10-year-old, but she has a lot. Her breasts are busy and she has a lot going on, even at that young age. And so moving forward, this is somebody who I would definitely want to watch very closely, because something's going on. And even though she looks average risk on paper, she's probably not average risk, And so every single month, whether it's an up-down motion or in a circle,
laying down, in the shower, figure out what works for you.
Figure out what works for you and do it. And focus not just on the breast, but go up into the underarm. The axilla is what we call that, because the breast tissue actually extends there. And furthermore, if there's actually something going on, a small mass, Every now and then, not always, you could have a lymph node there as well that's prominent. And so I tell patients to do this every month. It's easier for most patients to do it after their menstrual cycle because the hormones are at their lowest. Everything's kind of calmed down. The breasts aren't as tender. The breasts aren't as swollen. And so if there is something there, it's much easier to feel it. Another thing you need to watch out for, not just masses, if you have any skin changes, redness, all of a sudden your breast is swollen. I had a patient come in, this breast grew, it was the size of a watermelon when she came in, while the other breast was her normal C cup, D cup size. So if you have gross enlargement of one of the breasts, something is going on that needs to be evaluated. Any skin dimpling, nipple retraction, nipple areolar retraction, discharge, all of those things are worrisome signs that need to be worked up appropriately.
So I will never forget this. A few years ago, Chance the Rapper, I live in Chicago, so these things come across me. Chance the Rapper's aunt died of breast cancer, and she said before she died, she didn't think she had it because she had no symptoms. So I want you all to understand, you may have breast cancer and you don't have a cough, sneeze, nothing. So you need to please pay attention. And I will also never forget in med school, I saw a breast that looked like orange peel. It was all dimpled and we did surgery on it. I'll never forget that. That was in my general surgery rotation and I'll never forget it. But you guys, you need to pay attention. And the reason why you do it every month is so that you know if something is different. It is awesome that you go to the doctor once a year. God willing, you do that. And she or he will write down and make notes so they'll know what's normal for you too every year. But if something changes between those 12 months, you need to let them know.
And let's be clear, there are docs out there who aren't even doing breast exams in these streets, even for what's considered a wellness exam or a annual exam. I don't know in what world we're going to the doctor's office and we have physicians, mid-levels, whoever, who aren't doing full physical examinations. And so when I go to my PCP, I fully expect you to tell me that everything comes off, put this robe on, and we're going to check everything out. And so as we start talking about advocating for yourself, it's important that when you go to the doctor, you have your questions and you demand certain things. It's certainly your right. And if you don't feel comfortable with the care you're receiving, get a second opinion.
Or get a new doctor.
Get a new doctor.
I keep telling everyone, you're not tied to these people forever. Please, if something's not right, move on.
Yep.
We work for you. So, and we're a team. So if something is broken in the team, you're the coach. If something's broken in the team, then you need to go get a new team member. You can't stay going to a physician that you don't feel comfortable talking to, or if you feel like they're blowing you off or they're missing things. I had a friend who was less than 30. And she found a lump. She told the doctor blew her off and said she was too young. By the time that she was able to get diagnosed, she was stage 3.
Same thing happened to a girl.
She's still alive. She actually gave birth again after all her treatments and stuff too. So God is really shining on her, but it could have been a bad situation.
Absolutely. I had a patient with that exact same story, came to me summer of last year at the very beginning of the pandemic. She said, I feel a lump. This doesn't feel right. This girl is 27, 28, sought help, went to the doctor. Oh, this can't be it. It's probably just an abscess. Put her on antibiotics, brush her off. She makes her way to me, entire breast completely firm. There is no fluctuance, nothing to suggest an infection at all. Palpable lymph nodes underneath the arm. She had stage 3 also.
Yeah, so you guys, and and I know you want to say, well, I'm not 40 or I'm not. Nowadays, especially for Black women, unfortunately, we're finding it much earlier. So we really need to pay attention. And moms, grandma, aunts, whoever the guardian is, if it's dad, you need to teach your daughters how to do self-breast exams. You need to have that discussion when they start developing breasts so that they can get into the practice. And then it'll just be something that they do every month. And actually, there's apps that will remind you to do it. My Period app, I believe, actually reminds me. Yes, it does. It sends you a notification right after the cycle. Don't forget to do your breast exam. So it reminds you. So there's ways to do that. And I want to acknowledge there was 2 or 3 people already that said in the comments that they found their own tumors. Someone said, how do you know if the exam is thorough? So when you go to your PCP, there are several things you need to know. There's several numbers you need to know. So you need to make sure you know your cholesterol, your blood pressure, your if you're diabetic, well, even if you're not, you probably should know your hemoglobin A1C to know if you're pre-diabetic or if you are diabetic. And so that's a basic metabolic profile, of blood work. Then if you go into, especially the OBGYN, they should do a breast exam on you.
Yes.
And
Yes.
you should be completely derolled. Like she said, no clothes. They should check your breast. They should check for your ovaries. I mean, there's all sorts of things that need to be done as a woman. And you need to make sure that, and you can find this information online. I think I even did a blog post about what different things you need to have tested at certain ages of of your life. But you just need to make certain that they are doing everything so that you know everything. Other important thing, family history. Dr. Alexea, I know as a mother, so now she has history. If she didn't before, she has history to give to her daughter. If you are adopted, please try to figure it out because it is so important for you to know. Although, and I know Dr. Ryland will agree, there's a lot of people who are now getting breast cancer who have zero family history.
So 75% of people, 70 to 75% of people with a breast cancer diagnosis do not have a family history. And so almost everybody comes in and says, how did this even happen? I'm the only one in my family. Welcome to the club. Most people who get a diagnosis do not have a family history. And of that 20 to 25% who do have a family history, about 5 to 10% of that 20 to 25% will have a genetic mutation that has contributed to their breast cancer diagnosis. But let's be very clear. If you've decided that you're going to get genetic testing and it's negative and you have an extensive family history, that doesn't mean that there isn't something familial going on. And so even in those cases, I still counsel my patients on enhanced surveillance. And another point, when we were talking about dad, make sure your daughters know. Dad, make sure you know too, because I want to know that you are not exempt from breast cancer. Mm-hmm. Richard Roundtree had breast cancer. Montel Williams, Matthew Knowles, Beyonce's father. So you are not exempt from breast cancer. And so if you feel something, you need to say something too, and you need to regularly check yourselves as well.
Definitely. So once you're diagnosed, where do you come in?
I'm usually one of the first people that my patients see, which is awesome. I'm there from the very beginning. It's kind of like the quarterback. I help direct to other people they need to go to, whether that's the medical oncologist, because we need to start talking about chemotherapy or immunotherapy, other treatments that the patient will need, especially if they're advanced when they first come to meet me. Usually they see that person after surgery though. I send to radiation oncology, plastic surgery, psych services if I need to. So there's a lot of coordination of care that goes on after somebody gets a breast cancer diagnosis. And I don't know how other surgeons work, but I see my patients a lot. And so the relationship doesn't end after you've had surgery, or I would hope that it doesn't end with the surgeon after you have surgery. You should continue follow-up.
Perfect. We had someone say they were diagnosed in 1986. Wow.
How far we've come. And
yes.
Congratulations for being here and for being alive. Congratulations.
Yes. So recently, and actually maybe we'll get to talk about it on Black Doctor one day, but recently one of our Mocha sisters, her sister came out and talked about how she was avoiding having mammograms because she was afraid of radiation. I'm talking about Ananda Lewis, if anyone is old enough to remember Teen Summit on BET.
Yeah.
Ananda was the host, and she even had her own talk show at one point. But Ananda talked about how she's very holistic and natural, and she said she didn't want that radiation in her body, and her mother unfortunately got breast cancer even though she was getting the mammograms. So she said, well, I don't need to get them. And unfortunately, Ananda is now fighting breast cancer. And when she found out, she even says how much radiation she's had because of radiation treatment trying to get rid of this breast cancer compared to if she had just had her mammogram starting at 40. I mean, it's a huge difference.
It's a huge difference. And so y'all, the mammogram is not going to make you get cancer. Some of y'all, your pinky starts hurting and you want to go to the ER and roll through the CT scanner, which is a lot of radiation. You do this like once a month. Pause. You can't do that, okay? The amount of radiation you get from a mammogram is equivalent to a chest x-ray. And nobody thinks twice about a chest x-ray, but for whatever reason, when it comes to a mammogram, all of a sudden, you know, we pay a visit to Hotepland. You are not going to get breast cancer from a mammogram. We need mammograms, and mammograms have drastically reduced mortality rates across the board for Black and white women over the last 40, 50 years. If I can feel it, you're probably already stage 2. That's what I tell patients, because most cancers you can't feel them until they hit about 2.5 centimeters usually, unless you have a very small breast. And so mammograms are going to pick up non-invasive cancer, ductal carcinoma in situ, high risk lesions. It may not even be cancer yet. And so
yeah. So you want to please start getting your mammograms. I remember my physician, she did baseline. So I had a baseline mammogram at 36. Good. And then I went back at 40. And girl, at 40, they found something and it was a whole mess. I was like, I went in, no big deal. Mm-hmm. I had to fly out with my clients, the twin doctors. I'm sure you guys have seen them here on Black Doctor. We flew to Atlanta the next day, and I swear it went 24 hours, and they called me, and I knew. I was like, this is bad news. Why are they calling me? I just had this mammogram yesterday afternoon. And then they left a message. I called them back, and I could not get anyone for hours. Finally, I got somebody, and she said, oh, it was incomplete. I go, but I'm a doctor, so you could just tell me. She goes, it was incomplete. I showed up for this incomplete. And the woman's like, well, you know, they found it over here. So that's why I go, what? And when I tell you, I'm sure I turned white because I was like, I was in a state of complete shock because nobody told me. Mm-hmm. And so the lady, I guess she caught that I was in a state of shock. So she says, the tech was like, they're going to let you know the results of this before you leave today. And I said, thank God, because now I'm sick as a dog, you know?
Right.
And sure enough, I went and waited in this room and the nurse came and got me and she was smiling. So I just knew I was good. She said, so they found something. And I go, what? And she said, so you need to come back for a biopsy. We have an appointment tomorrow, 12:30. I said, I'll take it. And I had a biopsy the next day. And then this was before Memorial Day weekend. They were supposed to call me the Friday before Memorial Day weekend. They didn't call. I ended up calling them twice. They finally called. My mom, mind you, called 3 times. Have you called? I mean, she wrecked, you know, she's a nervous wreck. And they finally called and said it was nothing. And I was like, thank God. But I was scared to death. Right. And so I've been there and done that. Dr. Alexea, I would love to hear what happened to you in your story.
Sure. So I've been doing self-breast exams since I was 20. I started doing self-breast exams because I met a young Black woman who was dismissed by her healthcare providers for years and ultimately diagnosed with metastatic breast cancer around 21. And she toured the country telling her story to young college students, encouraging us to do self-breast exams and to advocate for ourselves. So I found my first breast lump when I was 21, entering into med school. And I knew my breast so intimately. That lump, it was like the size of a nerd's candy. And it grew rather quickly to a pea, to a marble. And by the time I got it evaluated, you know, had all kinds of inappropriate care, and ultimately landed in the hands of a woman general surgeon at my med school who finally said, you know, from physical exam, it feels like a fibroadenoma, but we'll get an ultrasound to determine that. And so that's exactly what it was characteristic of, was a fibroadenoma. It got larger and more painful over the next year. I had it removed a year later, and that's what it was. And I continued monthly self-breast exams for, you know, the next almost 15 years. And at 35, I found another marble size, you know, well circumscribed, could wrap my fingers around it, non-painful lump in my left breast, on a routine self-breast exam on a Sunday night. And please, y'all, do not let these internet, you know, quick, crazy self-breast exams that y'all see people doing in the breast cancer groups fool you. That is not appropriate. And that burns me up that in the breast cancer community of all places, we would, for social media, act like a self-breast exam is this quick thing that you can do in the span of a reel or, a stories clip. So take your time with it. So I found this lump, brought it to the attention of my primary care doctor immediately, went for ultrasound, was told preliminarily that it looked to be consistent with a fibroadenoma. But when the final read was done, it had concerning features and it was described as BI-RADS 4. At that time, my inclination, because I was a young doctor, newly single mom, building a practice, I don't have time to be sick. If it looks like a fibroadenoma, I wanted to be conservative and, repeat the imaging in 3 months. You know how you get those radiology reports, repeat ultrasound in 3 to 6 months or biopsy now, correlate clinically. So my clinical correlation was I was waiting 3 months and my primary doctor was like, heck no, you're a young Black woman. If this is breast cancer, it's going to be more aggressive. It's more likely to kill you. You got to go get a biopsy now. And she went with me and held my hand through this biopsy. And so that biopsy showed LCIS. And I ended up having a lumpectomy. And on the pathology from that lumpectomy, it did show LCIS and it also showed fibroadenoma, and wrapped in that fibroadenoma was ALH, or atypical lobular hyperplasia. So I had badly behaving boobs, and that took me in this path of high risk screening. So I ended up getting breast cancer screening every 3 months. Alternating with breast ultrasounds coupled with mammograms and MRIs as the alternate study. And after a couple of rounds of, image, biopsy, wait, repeat, I was put on tamoxifen and, still the same thing, still finding lumps, findings on imaging. And I said to my breast surgeon initially, like, can't I just get a bilateral mastectomy? Like, can't we just take away my breasts? Because, eventually I'm going to get cancer. And that wasn't even my frame of mind. That was my primary care doctor's encouragement. She said, you have ticking time bombs on your chest and they're going to eventually get you. You need to get your breast cut off. And so she's like, just cut them off and get a new pair. And, I took the advice of my doctor. So I presented it to my breast surgeon and his words were, it's too radical. And so I said, okay, well, what if I have a G mutation, right? Wouldn't that make me a candidate? And he said, you're not a candidate. You don't have a significant enough family history of breast cancer. And while I may not have had a significant family history of breast cancer, my father and my grandfather both had prostate cancer. And my grandfather's prostate cancer was very aggressive and it killed him. And on my mom's side, I had a family history of colon cancer. So while it may not have been, well, I'm not even going to say that. I'm not going to cap for him. I should have been screened then, but I was not. And because I was already in the care of a breast oncologist, I also said the same thing to her. Well, shouldn't I get a bilateral mastectomy? And she said, it's too radical. So I said, well, what about genetic testing? And she said, you don't qualify. And what qualifies somebody for genetic counseling is because their doctor said so. It may be a different story, and the genetic counselor should make that decision. But it costs us nothing to make a referral to a genetics counselor for a patient that's appropriate. And because I was having all kinds of abnormal breast imaging and all kinds of abnormal pathology on these biopsies. And it was, compelling enough for me to be put on tamoxifen even without a cancer diagnosis and to be screened every 3 months. So to say that anything was too radical was ridiculous. And I don't have better language for it right now. So when I was 37, still in this, cycle of routine screening, but I had been spaced to every 6 months imaging at this point. I had a mammogram and an ultrasound, which were quote unquote unremarkable. And I saw my breast surgeon to follow up and review that imaging. And he said, okay, well, next time, let's get an MRI, because that's where we were in the cycle. And he stepped out the room to write the orders and allow me to get dressed. And I was still getting my clothes on. And he came back in the room and he's like, you know what? Let's just compare oranges to oranges. Your last imaging was a MRI 6 months ago. Let's just get the MRI now. I don't want to wait 6 months to get it. And that MRI diagnosed my stage 3 breast cancer. It definitely was not there 6 months prior or 8 months prior in August of 2017. And the MRI that, ultimately diagnosed or uncovered my breast cancer was done in March of 2018. I'm actually coming up on the anniversary of that date now. So I had an MRI guided biopsy, and I've had enough biopsies to know that if there's nothing exciting about that pathology, you get that phone call in 48 hours. And so when 48 hours came and went, I was like, I have cancer. They're doing, special stains. They're doing hormone receptor testing. They're doing HER2 testing. And so 5 days after my biopsy, I finally got the call and was told that I had breast cancer. And, my cancer diagnosis was made because I did a self-breast exam. Even though the diagnosis was 2 years in the making, I was a 35-year-old woman. I was not on anybody's radar for a mammogram, and if I wasn't looking to make sure there wasn't something there or seeking to find an abnormality, I would not have even been in that 2 years of surveillance. Because I'll tell you that after a while, my breast, between biopsies, actively losing weight, trying to decrease my breast cancer risk, being on tamoxifen, which decreases the density of your breast. Even I didn't know my breast anymore after so many lumpectomies, biopsies. They were not, forget about, they're not twins, they're sisters. They were like cousins at this point. So having always been able to find a mass when I had one, or wrap my fingers around a mass that I had, after a year of living with, the first mass I found, where my cancer was, my tumor was 9.5 centimeters, but I didn't have a distinctly palpable mass. And I guess that, correct me if I'm wrong, Dr. Ryland, I guess that's maybe typical of the lobular carcinomas as opposed to
Correct.
ductal carcinomas. You don't necessarily feel a palpable lump or mass.
They grow differently than ductal.
Yep. But what I did have was this very subtle, dull ache over the right side of my breast that I only, really considered in retrospect. Like once I knew the MRI was abnormal and where the lesion was, then it was like, oh my God, I've been having that, like this very subtle ache. But of course, I was never asked about pain, and we're lied to. We are lied to. We are constantly told that if your breast is painful, it's not cancer, because breast cancer is not painful. And that's not true. And I know many women, apart from myself, who had either outright pain or, subtle pain over the site where their breast cancer was. So I had this very subtle achy pain there. Not enough to take a Tylenol or a Motrin for it. If I was working, seeing patients, I wouldn't even notice it was there. But if I was sitting writing notes or sitting quietly in my bed, I was very cognizant of that ache. And if I wasn't under constant surveillance, I probably would have brought it to someone's attention. But I always had a next imaging study coming, or always had something else going on. And no one ever said, bring pain to my attention. We always talked about, if you feel a new lump or bump, come back sooner. If there's nipple discharge or bleeding, come back sooner. The peau d'orange or breast swelling, all of those things I knew, but the ache just didn't occur to me. In my mind, I had so many biopsies, it was scar tissue, et cetera. And so we have to be careful to remind our high-risk patients of things like that, and if you're someone in the audience who is high risk, or you have a previous history, like, don't dismiss something because it's subtle. The other thing I had was very profound fatigue. And I mean, especially as women, and especially Black women, we will come up with every reason why we're tired. Well, I got these kids I'm running after. I have a spouse. I'm very busy at work. Of course I'm tired. But you were doing all of those things for however many years you've been doing those things without being exhausted. And I would come home from work and I would just kind of collapse in bed or collapse on the couch. And I would like, muster, just barely get through feeding my daughter and tell her like, you got to turn the TV off at this time or go to bed at this time. I'm out. And I would be unconscious. And it was so bad that when I went in for my surgery after my diagnosis, I had 250 unsigned charts because I was coming home from work every day and collapsing. So there's other subtle symptoms, but the breast exam is so important. And if I wasn't doing self-breast exams, I just turned 40 in January, according to the rule books.
Yeah.
Or if providers are not providing culturally sensitive care and giving Black women their screening mammograms at 35, I'd just be getting the first one. I'd be dead by now because my tumor was 9.5 centimeters and 9 out of the 15 lymph nodes that were removed from my right axilla had cancer that had spread beyond the capsule.
Mm-hmm. So, Dr. Ryland, we had a whole lot of terms in there. Dr. Alexea forgot.
Yeah.
But fibrous adenoma is basically a non-cancerous tumor.
Non-cancerous, benign tumor. I've never seen it, nor has that I know of. No one has ever reported malignant degeneration of a fibroadenoma. But, Dr. Alexea had so many other red flags. If somebody is repeatedly getting biopsies and every single time you were put on tamoxifen, every other biopsy is ALH, full stop.
What does that mean?
Atypical lobular hyperplasia. So abnormal cells of the lobules, if it starts in the ducts, atypical ductal hyperplasia. These are considered high risk lesions. And so these will increase your risk of developing a future breast cancer up to 4 times that of, general population. It's a high risk lesion for a reason. And so, especially in the case of abnormal ductal cells, those are considered, it's believed that ductal carcinomas, ductal cancers grow along a spectrum, with atypical ductal hyperplasia being the precursor to ductal carcinoma in situ, or the non-invasive ductal breast cancer. It is, please don't let people fool you. It is cancer. Lobular carcinoma in situ is still considered a high risk lesion. Dr. Alexea mentioned that term, but don't let people fool you. I had a patient come in this week. I was told I have non-invasive DCIS, that it's not cancer. No, it is cancer, and it gets treated appropriately with radiation if you choose to save the breast, and all the other things that we do to prevent this from happening again. And so she hit on a lot of amazing points. I would have absolutely triggered genetic counseling referral and genetic testing and had a discussion. If this keeps happening in your breast every single time, something is amiss, and I've with a story just like yours where we have gone ahead and pulled the trigger and done bilateral prophylactic mastectomies before it has turned into something else. I don't consider saving somebody's life and preventing them from having to deal with the cancer treatments and all the things that come along with that from an emotional standpoint, a physical standpoint, a treatment standpoint. There's nothing radical about that. Sorry, it's not.
No, not at all. Way back in the day, Renee Seiler, she used to be on CBS. It was CBS in the morning, same seat where Gayle King is sitting, basically. Renee made a decision because I think both her parents had breast cancer. And so she made a decision that she needed to have her breasts removed because she said, I've had my 2 children. They don't need them. I don't need this. And she, and it was a huge thing because the network, blah, blah, blah. And actually she got fired right around the same time. It was really weird. But she did that. And that was very public because she wanted people to know that this might be something you need to do. So she was like, please. And she was on Oprah, of course. And she's been on the Ask Dr. Renee show. So she talked about it on my show. But yeah, I remember she was the first person. And I think that might have been when I was in undergrad or something. It was a long time ago. And she talked about it. And that's what she felt was the best thing to do. And I think that people need to allow us to make decisions about our bodies. We've had this discussion about a lot of things when it comes to women and them not letting us choose what we want for our bodies. And I think that Dr. Alexea made a very valid point. I'm going through all this, I could just get rid of them and not have to go through all this. I mean, the
Exactly.
time, she's a doctor and she's a single mother. The time she has to take to go for a biopsy, for another MRI, for another, that's ridiculous.
It's a lot.
I was having, like, my first biopsy was on a lunch break. You know, I'm building a practice. It's very busy. I raced in the rain to the radiology suite. I know, it's crazy. After a while, I would take a day off to actually have biopsies. But my very first one was on a lunch break. I came back to work and continued to see patients.
You better than me. That biopsy, I was just like, no, I'm going home.
See y'all tomorrow.
Right. I was like, that was a whole lot.
I don't like that anymore. I've learned a lot about myself, how, you know, how dangerous the strong Black woman is, how dangerous it is to be, you know, Miss Independent, and how dangerous our medicine training is, that it teaches us to sacrifice ourselves and our well-being for the health of other people. So, you know, when I was sick and just reflecting on all of this craziness, you know, now I'm like, no, I don't work nights and weekends. No, I don't come in early. No, I don't stay late. I don't have it in me, because I had to go through this brutal cancer treatment. And, you know, I live with all the complications of that. You name it, I got it, you know? So yeah, when we're talking about young Black women who are more likely to die of breast cancer and more likely to get diagnosed at an earlier age with a more aggressive cancer, nothing is too radical, including cutting our breast off. And, you know, I was always the doctor telling people, you know, as an infectious disease doctor, you got to cut that toe off. It's going to kill you. Right. You know, you telling women who've had breast cancer, I'm sorry. Yes, I know you love your reconstruction. It's beautiful. That implant is infected. There's nothing I can do to cure it. It's got to come out. We can get it back in later. And so having told more people than I can count to take things off of and out of their body to save their lives, for me, that was a no-brainer. Like, if you would take these things off of my body, you can have them. And so to be told no is too radical, and sort of part of that being a physician was my downfall, because I'm a stay in your lane. Like, if I'm the ID doctor, don't come over here telling me how to do my job. I know what I'm talking about, but I also know that I'm always acting in my the best interest of my patients. And, you know, you almost assume that that is true for everybody else. And so I didn't advocate, I didn't push, I didn't fight, because two doctors in their lane told me the exact same thing. But the reality is the care was disparate and it was unacceptable. And, you know, this could have been avoided. So it took 2 years for me to finally have a diagnosis of breast cancer. And we spent 2 years not preventing it in the way that we should have. And, you know, or in the way that my doctor should have. I'm not taking responsibility for it because it was not my expertise. But had I known better, I would have just gone somewhere else or insisted that it happened there. So, you know, I share my story every opportunity that I get, because another young Black woman or another young brown woman, Latino, Latinx, you know, Indigenous, whomever is not going to get the standard white care, is going to be able to say, you know what, Dr. Alexea said that her breast cancer could have been avoided, and Dr. Renee or Ryland co-signed it. So no, doctor, I'm not walking out of here without the genetics referral or the test, or, you know, being considered for this surgery or taking the next step and doing the imaging, because I had that huge cancer and I was in that 10 to 15% of people whose breast cancer didn't show up on an ultrasound or a mammogram. And, you know, I'd see many women who have that story. And they don't know that an MRI is an option, or that maybe you should biopsy a site where there's symptoms, findings, and the imaging is negative. Somebody is going to be that person. And we cannot forget about genetic testing in Black people, who are 30 to 40% less likely to be offered genetic testing with a cancer diagnosis. So even though I had asked, once I was diagnosed with not just right breast cancer, because I now opted for a bilateral mastectomy, or to have a left prophylactic mastectomy, and there was cancer on the left side. So all of a sudden it went from, that's too radical, you're too young, you don't need that, you don't qualify, to you're too young to have breast cancer and you have it on both sides, something is wrong, you need genetic testing. and I have a PALB2 genetic mutation and an ATM gene variant of undetermined significance. And so, it's just one of those, too little, too late, I told you so kind of situations. So to, recount all of those things and to know that I asked for exactly what I needed and was denied and, got it when it was too late. It's just incredibly disheartening. And I just don't want that to be someone else's story.
But today you are cancer free.
Yes.
Amen. I have a girlfriend from med school who unfortunately is no longer with us. She knew something was wrong and she fought with Blue Cross Blue Shield. I'm sorry, I just have to say. And she fought because they would not get her the imaging that she needed.
Mm-hmm.
And then it came too late. She had kidney cancer as a kid and ended up with, and she had actually prophylactically had, I think, her reproductive system removed, but it ended up breast cancer, I think, is what killed her. So, yeah.
So, because kidney cancer, all these cancers at a young age, all these kind of things, all these crazy stories automatically trigger further workup.
Yeah.
I will say from that sense, I'm very conservative. If something even blinks funny, I'm like, oh no, we need to figure out what's going on. And just that not a lot of people feel that way is kind of, it's just crazy to me. But to Dr. Alexea's point about, a lot of things kind of happening around the age of 35, I think is important to know that for Black women, it's recommended by several radiology organizations. So Society of Breast Imaging, American College of Radiology, as well as the American Society of Breast Surgeons, that starting at 35, you should probably actually begin your screening mammograms at that age because we are more likely to be diagnosed with cancer, breast cancer, before the age of 40. And I got to tell you, I have a lot of women walk through my doors, 20s, early 30s with breast cancer. I saw at least 3 that were between 30 and 32 last week. So get it done.
Definitely, you guys, what you need to do is, if your doctor doesn't say it, you need to say, I would like to have a mammogram. I'm 35, or I will be 35 on my next birthday, and I would like to have a prescription for a mammogram.
I am not 40. I'm getting a mammogram tomorrow. Okay, so
see, she's not 40. She's getting a mammogram tomorrow. So I am 44, so I've been in the game for a little bit.
There are some states, like in New York State, you do not have to have a prescription for a mammogram. As long as you don't have any prior history of breast cancer, breast biopsy, or abnormal mammogram, you can go in for a routine screening mammogram. Correct. You just need to have a doctor to have the result forwarded to.
Correct. I did fellowship.
Well, what about it getting covered?
Your insurance will cover it.
It's covered.
It's covered.
Yep.
Okay.
It's covered. You can just say,
because maybe it's not in Michigan, because in Illinois.
Yes,
so in Illinois, they were like, we need a prescription.
It's covered.
The crazy thing is, I was trying to go and get a mammogram after the pandemic kind of wore down a bit. I said, well, I'll just go and get it, and they told me, my doctor is no longer allowed, because my doctor was out of state. They were like, we can't do the mammogram, because I said, but that's the only person that's ever prescribed them. And so because she gave the prescription, they refused to do it. So that's what I'm saying. Illinois might not be that way because they were not going to let me do that mammogram without this prescription. And so
state dependent.
Yeah. So you guys, please let your doctor know you would like to have a screening mammogram. And if you are in one of these states, which I'm sure you can figure out that information through your insurance company, through the internet, then if you're part of one of those states, then just go and get it done and then have it sent to the doctor. So when you show up for your annual, you can say, did you get the results to my mammogram?
Mm-hmm.
And it's important to note, if you don't have insurance or whatever, there are other organizations.
There are tons.
So American Cancer Society, they have branches in literally every state. Susan G. Komen, they do it too. And most state public health departments, breast cancer is so well funded because everybody from the richest person to the poorest person knows somebody and they have been personally affected. And these people donate millions. And so most departments of public health also have a fund. You may have to do some research and figure it out, but you can get a screening mammogram. And so please don't let insurance status be a deterrent. We already know that there are huge disparities between white women and women of color, especially Black women, as it relates to every single step of the process from screening to diagnosis, delays in diagnosis, delays in treatment, delays in surgery, all the way to survivorship.
Yeah.
This need not be so.
Yeah.
if a whole physician can have all these delays 2 years, then none of us are exempt.
Exactly.
So you got to push for yourself and advocate for yourself, and you need to have a doctor that's going to advocate for you too.
Unfortunately, Minnie Ripperton was very young. And so dying at 31, obviously she really, and think about it, mammograms in 1979.
It's crazy. Mammograms weren't even a huge thing when she was diagnosed. They only became more popular and in vogue in the early 80s. And so she had just missed the boat, right? And then I've seen mammogram images from 1980 versus what we have today. Those images are absolute trash. There has been so much growth in the medical industry regarding imaging, regarding treatments and everything. And so when she was diagnosed, I wholeheartedly believe that she definitely had extensive disease. And
then I know that she, like Dr. Alexea was saying, she was busy. She was actually about to put out an album. And so because she was trying to hurry up and get this album out, I think that she neglected her health, because she might have, her breast might have been deformed. I have no idea. But
I have no doubt that it probably was.
That's what I thought, yeah.
She had a radical mastectomy. That was popular 50 years ago. We don't do that in 2021. And so a radical mastectomy is basically what we came up with before the turn of the century. Dr. William Halstead, Google him. Breast surgery, you remove the entire breast, most of the skin of the chest wall. You remove all of the lymph nodes. You remove the pectoralis muscles, major and minor. It's a very debilitating surgery, and we just don't do that anymore. And so,
somebody Sharif Ali, bilateral mastectomy means both breasts. Because they said that might be the current name for radical. No, but you just heard her describe the radical mastectomy, and they don't do them anymore. And you heard why.
If somebody's doing a radical, you're going to be like, what rock? Like, run far away.
Well, they said, who did your surgery? No ugly scars, right?
We don't do ugly scars in 2021.
Right. Somebody had a very good question. They're very afraid of taking tamoxifen because of the side effects. Can one of you speak to that?
Sure.
I'm going to let Alexea go first. No, you go.
Okay, I was going to say tamoxifen can cause a number of side effects, but the most important thing I always want my patients to understand when I'm prescribing meds is a lot of times in those side effect profiles, the side effects can happen, as low as like 1 to 5% of the time. If it's really common, you might see it like 10, 25% of the time, but we tend to only accept that for the milder symptoms. So tamoxifen can cause a number of things like joint aches, hot flashes, of course, change in your menstrual period. So it can be more irregular or, less flow, heavier flow. For postmenopausal women, I want to say you have to have an OBGYN monitor the uterine lining to make sure there's no issues there. And that's a complication that's on the order of like 1%. You may see things like increased risk of blood clotting, which occurs but is an infrequent event. So if you are someone who has had a history of breast cancer, or you are very likely to develop breast cancer, though the side effect profile, even though it's pretty ugly, the side effect profile may be acceptable because the complications of a recurrent breast cancer or distant metastasis is much greater and much more concerning than the side effects of the tamoxifen. And then also, depending on your situation, tamoxifen may or may not be your only option. So you can give it a try, at the advice of your doctor, and just really closely monitor the symptoms. You can always start a prescribed med and see how it works for you. The other thing is,
get off.
and if it's not working for you, you can stop it. You can discontinue it. I have seen women also have a significant amount of mood disturbances with tamoxifen, depression, anxiety, things like that. And so again, like all other side effects, that needs to be monitored as well. But you can always stop it. It's not a medicine you need to wean off of or anything like that. There's no withdrawal from it. So if you need to be on it, it is certainly okay to start it, monitor your symptoms closely, follow up any labs that are of concern closely. And if you need to stop, you can always stop under the advice of your doctor. But remember, when you look at side effects of your medication, you're not comparing the side effects to doing nothing at all. You're comparing the side effects to what if this cancer comes back, or what if cancer develops, and you decide what for you is the bigger risk. That's how to look at it.
Let's just say this, for most of those medications, while most common side effects are annoying, the benefits far outweigh the risks as far as I'm concerned. And so a couple of things about endocrine therapy. And so one medication we mentioned was tamoxifen, but there are others that we give for women who are postmenopausal. If your tumor, so we're always going to check 3 things, right? So we're going to check to see if it expresses the female hormones, estrogen and progesterone. And we're going to check to see if your tumor expresses the HER2 receptor. That's if it's invasive. If it's not invasive, we're only looking at estrogen and progesterone. If it's negative, they probably won't put you on any of those medications because they know that this tumor was able to grow without the direction of your hormones. And so you just had something that just went kind of rogue. And so we're just going to monitor you very closely. But it's nice to have these medications because it's yet another tool in the arsenal to help reduce your risk. And so these medications will reduce your risk of recurrence by up to 50%. Some are a little bit greater than 50%, which is why we try to make a choice about which one we're going to use depending on the patient's particular case. And so if the risk of cancer coming back is 20% and somebody tells me you can cut that down to 10, this is a no-brainer for me. Yes, menopausal symptoms because of it. For premenopausal women, that's tamoxifen. We don't need any action from your ovaries, okay? We don't. Your ovaries tried to kill you in the first place by producing all the estrogen and progesterone and creating a cancer. In postmenopausal women, this is something also very common. Women will say to me, well, I'm in menopause, so I don't understand how this happened. Guess what? Your body is it's a well-oiled machine. Your body knows how to turn your fat cells and your hormones from your adrenal glands into estrogen and progesterone, which is why the other class of medications that we give you, they help to block that. So there's a lot of reasoning behind why we do what we do. And, some patients like it, some patients don't, and some choose not to be on those medications. And at the end of the day, it's not my job to tell you what to do. It's your body. And you're going to do what you want to do. But most people, they want to be around long enough to hit some other milestones, especially when they're getting diagnosed at 20 and 30.
Yeah.
Definitely. Are there any other questions? Please put them in. Somebody said, wake up, cancer is not for the elderly anymore. Exactly. You need to pay attention. Some girls grow boobs at 10. So if you have a 10-year-old with breasts, then you probably need to have a discussion with them so that they can check. Somebody else asked about dense tissue. I have dense breasts, and it's just me knowing my breasts. I know what's there and what's supposed to be there. And if something else is there, then I'll notice. And I will tell you, when they did the biopsy, what they found was so small. They showed it to me on the mammogram, and I was like, I couldn't see it. It was so small, and it was way back on the wall. So it was nothing I would have felt. It was not palpable at all. But definitely, if you have dense tissue, please just make certain that you know your dense tissue breasts.
Yes, and quick note: if you have dense breast, first of all, in every single mammogram report, they're supposed to report the density of your tissue, whether it's fatty or condense or extremely dense. Okay, so that's one thing to be on the lookout for, because that's information you need to know. It's going to help you. It's going to show you how you need to be moving when you go to your radiology appointments or to your doctor's appointments. An important note about mammogram: it's a great screening tool, but it's not perfect. So the more dense your breast tissue is, I have women with extremely dense breast tissue where you can't see anything. Mammogram can miss up to 30% of cancers in women with extremely dense breasts. Okay. So at that point, we need to be adding some adjunct imaging, right? So whether that's you get ultrasounds along with your mammogram, some women, their breasts are so busy and so dense that even if they aren't considered high risk, that dense breast tissue is putting you at risk because something could be hiding there and we don't know it. And so in those cases, I always add in MRIs for my patients. And so they know, no, I don't have a family history. No, I'm not high risk, but my dense breast tissue itself poses a risk. And so we enhance their surveillance. And so that's something else to be mindful of.
Absolutely. I had dense breast also. Yeah.
And so for treatment, what did you decide to do? Oh, you said bilateral mastectomy?
I did bilateral mastectomies. I had chemotherapy. So the other thing about, cancer genetics, it's important to know if you have a cancer gene mutation or not, because it can guide some therapy. So I have a PALB2 mutation. It's treated like a BRCA2 mutation, and in BRCA2 positive breast cancers, they add carboplatin. Now, if we didn't know that about my genes, that medicine would have not been added to my regimen. So I had 4 chemotherapy drugs. I had radiation. I had 25 cycles of radiation therapy. I had lymphedema. I developed it early after surgery, and then it was exacerbated really dramatically by my radiation. And now I'm on hormone suppression therapy with letrozole and Zoladex injections, which I get monthly. I didn't go on tamoxifen, which I would have otherwise based on age and being premenopausal, but I went on the aromatase inhibitor because I developed cancer on tamoxifen. So we weren't going to take a chance and go back to that particular drug. So I remain on that. I'll be on that for 10 years. At some point, I will probably have my ovaries removed. And because I know my cancer genetics, I'm at risk for pancreatic cancer. So I'm in a pancreatic cancer surveillance program, which there's very few in the country. And you cannot enroll into that kind of screening protocol unless you have a known risk. So it would have to be a strong family history or a genetic risk factor. So, the more we know, the better and more appropriately we can be taken care of for our individual bodies. But for, Black men and women specifically, we have to have culturally competent care that considers how high risk we are. And again, don't ever let a doctor tell you something is too radical when you're living in a body that, you're more likely to be diagnosed at a younger age. Your cancer is more likely to be aggressive and it is more likely to kill you for so many reasons. And it's not just the cancer, it's the systemic issues as well. And so we just have to call people out and really help, advocate for ourselves and help guide and direct the care that is provided to us.
Definitely, definitely. Now, I've never met either one of these ladies, but I've seen you guys. So, Dr. Alexea, I started following you, I think, because I saw you in Mocha and they said, oh, she's got cancer. And I started following you then. And so I remember you doing videos. She didn't have any hair, you guys. You see all this hair she has now. So I remember, and I was like, oh, my goodness. And so it's good to see that you are well and that you will be celebrating that anniversary this month.
Yes, thank you.
So where can I see Dr. Alexea? That is your Instagram?
That's my Instagram handle. That's my that's my Facebook handle. It is my Twitter handle. You can find me everywhere at Dr. Alexea. My website is dralexea.com, and I'm Dr. Alexea on Clubhouse. If you're over in that space, Dr. Ryland and I have been in several conversations on that platform together and look forward to several more in the future. So you can follow me for all things, breast cancer, cancer genetics, cancer awareness, and just, healthy lifestyle. I understand that we, live a life of total health and wellness, especially cancer wellness for those of us who've experienced or know we are at risk for any cancer diagnosis, but particularly breast and ovarian cancer.
We have a good question here. I have dense breast and I'm triple negative breast cancer survivor. I was diagnosed December 2014. I had chemo, lumpectomy, and radiation in that order. Even though I'm getting mammograms annually, I'm not having ultrasounds or MRIs. Should I request one or the other?
I would. Short answer is
yes.
So both of them shook their heads yes on that one.
Yes. Long drawn out answer. Yes.
Yeah. I'm like, yeah.
Absolutely.
So please, you guys, take this great information. Dr. Ryland, please tell everyone where they can find you.
I should have been like Dr. Alexea and, multitask. I can be found Ryland Gore, RYLAND GOREMD, and that's across platforms. Twitter, I'm not as active on Twitter, but Twitter, Instagram, Facebook.
Ryland Gore, MD?
Yes, Ryland Gore, MD. And that's also on Clubhouse as well. Yes, exactly.
Yes. So everyone, I will try to put everything in the post in YouTube and in Facebook so you guys can find them. But here are two people that gave us a whole lot of information today. And I hope that this was helpful. Okay, somebody said I was not given a PET scan because my lymph nodes were clear and my onco was a 4. Should I request one?
Not necessarily. So I will say this. If I'm ordering a PET scan on somebody, be afraid. I'm worried about you. And but it is important to note that for patients who are, you sound like you were still considered early stage, so stage 1 or 2. But for patients who are stage 3, and certainly, God forbid, you're diagnosed as, or there's a high suspicion for stage 4. But if you're stage 3, they should be, insurance should be covering a full workup. So that's a bone scan and a PET CT. I always do MRIs on most of my patients as well to get the full extent of disease in the breast. If they won't cover the PET CT, a chest CT of the chest, abdomen, pelvis, as well as a bone scan, they usually can do all of that.
Thank you. Thank you. So if you guys have any other questions, you know how to find these ladies. And thank you guys so much for giving me your time this evening. This was very informative. And I do apologize. We had some acronyms, but we did get them all. Take care. We had somebody that said something about that. So, but we got them all, deciphered.
Sorry.
So please make certain that you do your breast exams. That's the biggest takeaway, is if we can do our own, then we can find it probably faster than the doctor can find it. So let's make sure that we know, you've seen the slogan, know your girls. Let's know our girls so that we can definitely prevent this from happening. Like we said, Minnie Ripperton was 31 and God knows she was an amazing talent. And can you think of all the amazing music we would have had she lived longer? Thankfully, she did give us her fabulous daughter, Maya Rudolph, who cracks us up on a regular basis and is extremely talented. But yeah, let's please look out for each other. I mean, Robin Roberts, there's been so many Black women that have had breast cancer and thank God have survived it. But for those that have lost their battles, we are so sorry. And we just need to, knowing is half the battle, as they said on G.I. Joe. And the earlier you know, the better it is for you.
That's right.
You got to know early. So don't not go to the doctor because you're afraid that's what it is. Go to the doctor so that you can find out if it is or it isn't.
Yeah.
So, because a lot of people are like, well, I don't want them to tell me bad news. No. Just go, because there's something they can do about it. As Dr. Ryland said, breast cancer has had so much research done and there is so much money put behind it. There probably will be a cure very soon because there's so much money behind breast cancer research. So they can probably treat it, and you could be like Dr. Alexea, stage 3. If you know anything about cancer, it's usually 1, 2, 3, or 4. Stage 3, and she's still here with us. So that tells you that things can be done.
Yes.
So we will see you again next week, you guys. Thank you so much, and everyone have a fabulous evening.
Thank you.